It's the 15th of October, 2021. This is the RheumNow Podcast. Hi, I'm Dr. Jack Cush, Executive Editor of RheumNow.com. I've got a new quote. I've got a new word. So you're wondering what that might be. My new quote. Adam Grant's got a great podcast. His quote is, "Don't confuse being a fast talker with being a deep thinker. Speaking quickly signals confidence, not complexity. And don't mistake volume for expertise. Speaking loudly reflects conviction, not credibility." These worry me as I'm kind of loud and I talk kind of fast. Sometimes the best ideas come from the least assertive voice in the room. I think that's actually true. But I'll steal a line from Ethan Craig, who retweeted this for me. He said, "As a loud, fast-talking man that has no idea what he's talking about, he can vouch for this quote." Thank you, Ethan. I'm going to mirror your comments. So my new word of the week is quackademic. I loved it. Quackademic. It's what? It's an academic center person who's doing quackery research. This was a title I found in something about stem cell research trying to treat autism being done by a prestigious medical center, hence quackademic. You know, you could spin this off and go a lot of different directions. Crackademic, academics who just don't know when to stop. You know, they've got a crack-like mentality to everything they do. Shackademic, that would be an incredibly big-time academician, the ones we'd like to have as friends. I could think of a few shackademics that are running around these days. So let's go on with today's report. A lot of nice reports, a lot of nice research has been put out this week, and a few interesting announcements. A simple report we'll start off with comparing the risk of acute uveitis in spondyloarthritis patients based on the therapy they take. You know the answer to this. Patients on monoclonal antibodies against TNF inhibitors have the best and lowest rate of incidence and recurrence. That would be infliximab and adalimumab. Not as good for Abatacept. This particular study compared in over 5,000 new drug starts, about 500 starting secukinumab, the IL-17 inhibitor, and 4,500 starting one of the three TNF inhibitors. The risk of acute uveitis was actually similar between Abatacept and secukinumab. Secukinumab's risk was about 7 or 6.8 per 100 patient years, and with Abatacept 7.5. It was significantly lower, 2.9 and 4 with infliximab and adalimumab respectively. So secukinumab seems to have a 2.3-fold higher risk than the TNF inhibitors when it comes to the development of uveitis. So it might have some marginal effects, but if that's what you're looking to do, IL-17 is probably not your best agent. A really interesting study about CXCL13. This is one of the chemokines that's out there. CXCL13 is involved in B cell migration to germinal centers and lymph nodes and whatnot. It seems to be a good biomarker in certain leukemias and lymphomas, T-cell lymphomas. This particular study looked at its utility in 158 patients with early RA who were followed over an 11-year period. And they looked at a lot of different biomarkers trying to predict future radiographic worsening. That would be change in total Sharp score and erosion score. And in this particular study, they showed that CXCL13 did correlate, baseline CXCL13 levels did correlate with the risk of future X-ray progression 11 years later. In fact, CXCL13 was superior to CRP-28 CRP, swollen joint count, and CCP in predicting future erosions. It's a chemokine. Again, there's not a lot of attention being paid to chemokines these days. I think we probably should be taking a second look at that and find out where their utility may lie. This is a good example of where it's performed well. The risk of infection with biologics, always something on your mind. I don't know if you've noticed the results that I've seen and talked about over the years, but you know, RA's got a well-known number of serious infectious events. Pre-biologic area, it's 3 to 9 SIEs per 100 patient years, and 100 patients followed for a year. Somewhere between 3 and 9 taking methotrexate, gold, Plaquenil, whatever, would end up with a hospitalizable or serious infection. In the biologic era, the numbers actually went down. Most of the biologic studies are somewhere between 2 and 5 SIEs per 100 patient years, which generally in an ideal patient means that biologics don't cause a serious infectious risk. But those are the numbers in RA. If you look at the numbers of same drugs, whether it's adalimumab, for instance, or any drug, a JAK inhibitor, for instance, the rates of SIEs are much lower in psoriatic patients, psoriasis, and psoriatic arthritis than in rheumatoid arthritis. And I say my interpretation of that is rheumatoid arthritis and, for that matter, IBD are much dirtier. There's a lot more comorbidity. There's a lot more systemic full-time inflammation in play. That's why you see slightly higher rates compared to psoriatic disease. And this particular study looked at that. 2,400 RA and PSA patients started on a TNF inhibitor, and they looked at the rates of serious infections, and it was higher in RA, 4 per 100 patient years in RA, and 2 per 100 patient years. It's double in RA than that's seen in PSA. Again, I'm reporting it because it always backs up my beliefs. I don't know if that's really good science, but nonetheless, I think it's important to know. I've got a 6-pack of Still's disease for you. You know I'm interested in Still's disease, and that means you're along for the ride, whether you like it or not. Here are 6 reports. Number 1, a retrospective study of almost, 534 new onset systemic JIA patients from 52 tertiary medical centers to children's hospitals in the United States, looked at what drugs they were treated with at presentation. Presentation, as you know, is always systemic, hot stuff. Bad lab, patient sick, high fevers, rashes, organomegaly, etc. What were they started with? 29% were started with biologics, 58% steroids. They did show that over time, biologic use increased and that methotrexate dependency decreased. Biologics were correlated with the volume of the hospital, whether or not the patient was likely to go into the ICU, and then later years of observation. This was done between 2008 and 2019. Report number 2, a comparative study of 46 Still's patients, 9 patients with MAS and 31 adult HLH patients, looked at IL-18 levels and its value. Turns out IL-18, serum IL-18 levels was much higher in patients with Still's, adult onset Still's, than the adult HLH patients. And it correlated best with ferritin levels and soluble IL-2 receptors. Overall, if you want to distinguish between Still's disease, or AOSD, and adult HLH, IL-18 levels, IL-2 receptor levels, and the presence of arthralgia and arthritis could distinguish between those two. Report number 3, smoking is bad in Still's disease. Well, this is not a shocker, but nonetheless, it's adding to the list where smoking makes things worse. It's not only RA, it's PSA, it's SPA, it's JIA, it's lupus, and now Still's disease. In this particular study, 185 Still's patients, 45 of whom were smokers. Yes, the smokers had worse disease, as exemplified by double the rate of pericarditis and pleuritis and abdominal pain, a higher systemic activity score. They had more episodes of macrophage activation syndrome, 29% versus 6% in non-smokers. They had more parenchymal lung disease, 19% versus 13%. Not a good idea to be smoking if you have an inflammatory arthritis. Report number 4 in the Still's disease 6-pack. There's such a thing as catastrophic Still's disease. I didn't know that until I read this. They call catastrophic Still's disease any Still's disease that leads to organ failure or significant organ compromise. So they compared 20 patients with organ compromise to 40 without organ compromise, and they showed that the patients who had catastrophic Still's disease had shorter disease durations and an earlier need for systemic therapy. What does that mean? That means that they had more acute systemic presentations with a rapid onset. And that means that you're more likely to have organ involvement, liver, lung, heart doesn't usually get involved, splenomegaly. The ones who are at risk here, they tend to be younger, they tend to have splenomegaly, liver, cardiac, and lung involvement, and higher ferritin levels. And interestingly, no arthralgias at presentation. That's number 4. Number 5, Well, it's kind of stills. It's talking about anakinra. It's a meta-analysis of anakinra's utility in COVID. And based on this this analysis of nearly 2,000 patients, that anakinra was significantly effective at lowering mortality risk, almost a 70% reduction compared to historic controls, in patients who had severe hospitalizable COVID-19 pneumonia. So if there was evidence of hyperinflammation with extremely high ferritin levels and extremely high CRP levels, it was maybe even more effective, almost an 80% reduction in mortality. Interestingly, this meta-analysis that comes out the same week as does the EULAR recommendations on COVID management in rheumatic patients, where they did not endorse either colchicine or anakinra, saying that the data was not yet robust enough. I don't know what robust means, but I think there's a lot of data. There's at least 4 really good reports that, as good as it gets, at least in COVID, that suggest that there's a beneficial effect to anakinra. Now, would it be as good as, or is it as good as, the current rage of using tocilizumab and IL-6 inhibition? I think head-to-head it would be. But then again, such studies have not been done. My last report in the 6-pack was a report from yesterday where I saw another ridiculous report on Still's disease associated with this, associated with that. Most of those I just, say nothing to, or because, for instance, Still's disease associated with pregnancy. Well, Still's disease is a disease of young people. Half of them are males and half are females. So young women can get Still's disease, young women can get pregnant. There's no association between Still's disease and pregnancy, good or bad. It just seems it's a co-occurrence. And what happens with another disorder, it's another co-occurrence. But I saw these reports in the last week or two of Still's disease occurring following COVID-19 vaccination. And I thought, well, that sort of rang a bell. It rang a bell in that there are reports in that literature, systemic JIA and Still's, that there could be viral onset triggers to the disease. There are reports of Still's disease occurring following either pneumococcal or influenza vaccinations. So I found 4 good reports with all the cases lined up. You can read it and look at all the cases. They're all pretty interesting. There's one 22-year-old, a 35, a 36, and a 42-year-old. They all had high fevers. They all had rashes, and all but one had arthritis. They had all the other things you'd want to see. They met the criteria of Yamaguchi or Fautrell. I didn't test my criteria in this because that's not the point of this. And they had white counts of greater than 50,000. They had ferritin levels. One was 2,100. The other one, 2 were over 50,000. Again, this is impressive Still's disease. And they all occurred, 3 of them occurred 3 days after their last vaccination. And which vaccine? It was with Moderna, Pfizer, and the adenovirus vaccines. So non-discriminatory. 3 to 5 days later, the onset of features, a history of disease that played out over 2 to 4 weeks, and in at least 2 of the cases they resolved, and 2 of the cases continued, and they were on systemic therapies like anakinra and steroids. So what does this tell us? Again, Still's disease is an autoinflammatory disease. There's activation of the NLRP3 inflammasome. And we know that we can activate that inflammasome by certain molecular patterns, including pathogen-associated molecular patterns, or PAMPs. And then there's also DAMPs. But the PAMPs are infectious agents. And again, we do know that SARS-CoV-2 will lead to inflammasome activation. We do know that binding of the spike protein to ACE2 receptors leads to downstream NF-kappa B activation and IL-6 generation, and subsequently more IL-1, and feedback to further amplify the inflammasome activity. I mean, there are a few mechanisms by which this may happen. So it could be that SARS-CoV-2 could do this, and there are 3 cases out there that I've seen of kids with systemic JIA who got worse after they got COVID-19. So SARS-CoV-2 could start this. The question is, why does someone get Still's disease? The inflammasome activity is a normal innate immune response it becomes still disease when they don't turn off. So that must be other factors, other epigenetic changes that's acquired, and we don't really know the etiology of this. But I find this association with COVID vaccination interesting. Speaking of vaccination, let's talk about hepatitis B vaccination. A nice report of almost 2,000 patients, I believe this was done in Korea, who underwent serologic testing from 2003 to 2019. They found in this group 489 of the 2,000 who had a history of resolved hepatitis B, occult hepatitis B. Those would be patients who are hepatitis B surface antigen negative, or hepatitis B core antibody positive, and they may or may not be hepatitis B surface antibody positive. As you know, the surface antibody is what you get when you are vaccinated against hepatitis B. You may get it and keep it or lose it if you had infection with hepatitis B. In this particular study, they looked at what happened as far as reactivation when these individuals were taking biologic DMARDs. So with like 67,000 person months of follow-up, they had 27 patients, or 5.5%, who developed reactivation of hepatitis B. And guess what the drugs were that were most likely to lead to reactivation? By the way, if you're on a TNF inhibitor and you're in this profile of resolved hepatitis B, occult hepatitis B, your risk of reactivation is said to be low, 2%. That's a combination or a conglomerate of many different studies put together, and that's the number that I see. In this study, it's 5%, 5.5%. The drugs that most likely led to reactivation, Rituximab, an 88-fold increased risk. Next on the list, interestingly, Abatacept, a 61-fold increased risk. And the other factor was if you did not have any hepatitis B surface antibody at baseline when you started the drug. So being Hep B surface antibody positive does have some protective effects when you're starting these biologics, the TNF inhibitors. But if you're going to use rituximab, the current ACR guidelines say that you should probably consult a hepatologist and the patient should be on background antiviral therapy. The same has not been said for Abatacept, and I think there has been hints. Dr. First had a report about Abatacept and Hep B reactivation about 10 years ago. This needs a further look, but I would be cautious with Abatacept. There's a cancer risk in lupus. Everybody knows that. It's small. Other past reports have said it's related to age and seen more in men and smokers. In this particular report by Bernatsky and colleagues from Canada, they looked at an incident lupus cohort of nearly 1,700 patients, followed for 9 years, and found a total of 65 cancers, most of them being breast, 15, non-melanoma skin, 10, 7 lung, 6 hematologic, 6 prostate. What were the risk factors for developing a cancer if you have lupus? It mirrored what was been seen before. Males, older individuals, smokers. There is an association with disease activity in some cancers. And the other interesting factor from this particular report was that use of hydroxychloroquine was somewhat protective against breast cancer and non-melanoma skin cancer. Yet another reason for everybody to be on vitamin H, hydroxychloroquine. I found this particularly interesting, and that is a report suggesting there's been a decline in the rate, the incidence of Behcet's disease in Korea between 2004 and 2017. The rate in 2004 was 8 per 100,000 individuals. By 2017, that's 13 years later, it's down to 1.5, from 8.1 to 1.5 per 100,000. That's an 82% decrease, more so in women and middle-aged individuals, but really no change in survival or mortality, which is obviously low. But the question is why? The genetics probably did not change during this period. What did change environmentally? That's an interesting question. And the other question is this going to be seen in other populations worldwide? Nonetheless, I must say I don't see very much Behcet's anymore in my practice. I used to see a fair amount of it. I used to think that a lot of Behcet's was a cold sore and fibromyalgia, but there is real Behcet's, oral, genital ulcers, eye inflammation, gut inflammation. Again, then they're difficult to manage, right? Luckily, we have some new drugs for that. So the big news this week was the FDA approving the drug Avacopan, the C5a inhibitor for use in ANCA-Associated Vasculitis, based on a number of trials. We've covered that at ACR in the past, and also recently the FDA hearing, which, by the way, the FDA hearing wasn't a good hearing. I mean, it was sort of a split decision by the advisory panel, but yet the FDA has gone ahead and approved this drug for use in ANCA-associated vasculitis. And again, the controversy here was it didn't meet its primary endpoints at week 24, but it did at week 52. I think I like having another option other than steroids, but when you compared Avacopan to steroids, obviously expensive and cheap, there wasn't really a tremendous safety benefit to Avacopan. And that I found particularly bothersome, but let's see how it does in the real world, and that's you. You're a real doc in the real world. Let's see what you do. Retro. We've been talking about retro a while. Finally, it shows up in press. This is a 303 rheumatoid arthritis study where the patients were in remission, DAS remission of less than 2.6 for at least 12 months, and then they get randomized to 3 different groups. 1, no change. They stay on their same therapy. 2, they taper their therapy. And then the other group is they taper for 6 months and then they stop after 6 months. And the risk of relapse, as you can imagine, was best, meaning no relapse rate was highest in those who continued, 81%, a lot less in those who tapered, 59%, and really a lot less in patients who stopped, 43%. Or the converse of that would be the number who actually relapsed. The risk of relapse was 3-fold higher if you tapered, 4-fold higher if you stopped. I look at this and say, don't stop, don't taper. You work your whole life to control rheumatoid arthritis. Don't play this game. This is really stupid. But yet, I know you're forced into situations where patients want to stop. And as the ACR guidelines and other guidelines have said, 'tis better to taper than to stop. Again, don't endorse it unless you're forced to. There's a report about triple DMARD therapy, and what if the triple DMARD therapy, instead of methotrexate, sulfasalazine, hydroxychloroquine, was a substitution of leflunomide for sulfasalazine? So methotrexate, leflunomide, hydroxychloroquine. How do they perform? 136 patients, active RA, open label study. At week 12 and week 24, the response rates by EULAR good responses were equal. Hence, you can substitute leflunomide for sulfasalazine if there's an issue of sulfasalazine tolerance. My belief is that methotrexate leflunomide is a fabulous combination by itself. I don't know that it needs another drug like hydroxychloroquine, but worldwide, that combination of methotrexate and hydroxychloroquine is cheap and widely used and very effective, especially in places where they don't have a lot of biologics to use. Janet Pope tweeted this interesting report from the CERT study. As you know, that's the methotrexate prevention trial where they looked at the effect of methotrexate on kidney function. And the bottom line is that there was very little change in kidney function in those treated with methotrexate. And if you had mild renal impairment, you didn't have any hit here. So it basically says that you should still follow creatinine. It's a risk factor for methotrexate toxicity, but mild renal impairment can get methotrexate as long as you monitor them. That's, again, good data coming from this CERT study. The Abatacept announced its results from 2 phase 3 select Axial studies. These are studies done of Abatacept and the selective JAK1 inhibitor in patients with axial and non-axial spondyloarthritis, and both of them did very well compared to placebo. And are going to be part of the portfolio presented to the FDA for further consideration as a new indication. Lastly, we have a worrisome report about women doing much worse than men with axial spondyloarthritis. I don't know if you follow this literature, but it shows up over and over again. We know spondyloarthritis is a tough disease. Women with this disease are under-recognized. They often get diagnosed later. They often have more pain. This study of nearly 500 patients, a third of whom were women, basically showed women, compared to men, have higher disease activity, higher joint counts, higher enthesitis scores, more pain, worse fatigue, worse function They have less full-time work. They are more likely to receive DMARD therapy, prednisone, and they suffer from more depression, fibromyalgia. You're going to have to work harder if you're taking care of a woman who has axial spondyloarthritis. I'm going to end with just a simple case report of post-COVID-19 reactive arthritis. And there's actually been a few in the literature. I've not covered them until now. This particular report only had dactylitis, had no oligoarthritis, but dactylitis, and had psoriatic skin and nail changes, painful oral and vaginal labial ulcers, subungual keratosis, onycholysis, but no back pain. It's been seen, and it follows the pattern of a reactive arthritis. So that's it for this week. Check out our citations and more. Be sure to follow our ACR coverage. A recommendation for you: go to your registration RheumNow and your registration profile and check a box on what topics you'd like to receive post-ACR. Following ACR, if you're getting a topic email like I'm interested in lupus and I check that box, I'm going to get an email that's going to tell me what new lupus reports appeared on RheumNow this past week. But after ACR, you're going to get all the ACR reports on lupus sent to you in one email. It's a nice way of getting content after the meeting. So I hope you enjoyed this podcast. Be sure to listen up.